Good afternoon, everyone, and welcome to our webinar entitled Alignment and Parity amongst the MSSP and MA Payment Models. MSSP referring to the Medicare Shared Savings Program and MA referring to Medicare Advantage. And this is sponsored by Salient Healthcare. We're a subsidiary of Salient Management Company, and we are really excited to host our first webinar with ACO Exhibit Hall. So thank you, Garrett, for having us. The topic of today's discussion is one that truly hits close to home. For any provider organization that has multiple payers, you know that it's extremely important to understand how to work with your rules and your contracts so that your providers and patients are ultimately the ones that benefit from these value-based contracts. Now, throughout our presentation, we're going to do some polling, and I'm going to start with our first question, and I'm going to release that for you. And that question is, which types of payer contracts are your organizations involved with? So I'm going to give you a couple of seconds to answer what parts of these contracts that you're involved with, and then once I see that a number of you have answered, I will provide you with the data. All right, let's see. Okay, responses have somewhat slowed down, so I'm going to close this for now, and we can get a look at what everybody has, and I'm going to share those results. So you can see that the large portion of our audience is involved with Medicare ACOs, whether they're part of the Shared Savings Program or NextGen, and actually as of the start of this month, some of you might be involved with the Pathways to Success model. And then we have a split between Medicare Advantage and Medicaid, and a few of you are actually involved in commercial ACOs. So it's really interesting to see the mix amongst our audience members. So thank you. All right, let's continue. So I'm going to provide you with today's agenda. We're going to begin with a brief introduction as to who Salient is. We take a lot of pride in our company's longevity and ethos, so we want to share that with you. And then we're going to move into the importance of today's discussion, followed by a brief understanding of the Medicare population, just to lay down the foundation for further discussions. That will then be followed by the meat of this presentation, and that's the next two bullets after that. That's the similarities and differences across your Medicare Advantage and Shared Savings Program contracts, followed by the necessary resources and infrastructure needed to truly comply and excel in your value-based model space. There will then be a quick conclusion, and then we'll have plenty of time for Q&A. And just a reminder, we'll do a few more of those polls throughout, so we hope that you guys participate as well. So a brief introduction as to who Salient Healthcare is. We find that our background is really unique in a sense that we stem from a much larger umbrella corporation that opened up shop over 30 years ago in the bottling industry, working with clients like Coca-Cola and Pepsi. And it's unique because they created this solution for transaction analyses, and it was this giant engine working these really large Fortune 100, Fortune 500 companies. And then over 13 years ago, they realized that the same solution could be used in the healthcare space. And so then we began working with the large enterprise system, which meant that we had to solve for scalability and governance at the start of the program. And we started with the New York State Medicaid enterprise. So that's billions and billions of transactions, a lot of historical data. It's about over 13 years of historical data being housed there. And so then from there, we then moved directly into the Medicare space with the Medicare Shared Savings Program and Next Generation ACOs. And today we're working with a lot of Medicare Advantage and ACO commercial plans. So we've had a movement towards the healthcare space, realizing that this big and powerful solution that was originally created for just, a bottling system was able to accommodate all of these other healthcare organizations. And compared to the Medicare ACO data set, that's pretty small when you're looking at the New York State Medicaid enterprise. So it's something that was tangible and easy to use, yet we were able to use the same powerful solution across all of it. And you'll notice the stars represent our location globally, and healthcare-wise, we are across the entire United States. So now that you know who Salient is and the space we're in, I'm going to introduce you to today's speakers. Our first speaker is Salient Healthcare's own Chief Medical Officer from North Carolina. We have Dr. Cragen Gray, who is nothing short of impressive. He's got a JD and MBA that follow his doctorate, as you can see. He's got all the alphabet. And he has had over 30 years of clinical experience. He even delivered one of his own children. He was an OBGYN. He had a focus in breast cancer, and he was the former Medicaid director for the state of North Carolina. He's held many other well-regarded positions, and what's notable with Dr. Gray, as you can see, is his love for music. He's a trumpeter, and he likes to jam with the band. Next on our list is myself, Amy Koch. I'm the lead business consultant, and I've worked with over 25 ACOs and MSOs around the country since 2014. The majority of my focus has been on policy and workflow transitions to value-based payments, so a lot of transition work. And my fun fact is that I am an advanced open water scuba diver. I live in South Florida, and I go pretty frequently with my husband. And last but not least, coming all the way from Annapolis, Maryland, we have Maria Nickel, who has a unique master's in jurisprudence, as you can see, that MJ. And that means we have a policy expert on our hands. So Maria has worked with a number of ACOs as well as with PCMHs, and she helped to develop operational strategies. In her spare time, she's a figure skating teacher and competes occasionally. And following those introductions, I'm going to let Maria take it away to discuss the current healthcare landscape with regard to Medicare Advantage and the MSSP.
Thanks, Amy. So as everyone is likely aware, there has been a lot of evolution in the healthcare landscape lately. However, one thing that stayed constant is the bipartisan support of value-based programs. While they were originally created by the ACA, the Trump administration continues to support value-based programs. In March of 2018, Alex Azar stated that they will dramatically accelerate the development of these programs, and Seema Verma continues to support these projects as well. At a recent NACOS conference, she indicated the development of these programs will be accelerated. So on the next slide and through this presentation, we will address why we need to focus on Medicare. There's definitely a strong need to manage the Medicare population because of the continuous growth of the Medicare population and the increase in the payments to MA plans. While you'll have multiple contracts, and the callers on our call likely do, it's really important to identify the parity across these contracts to help manage the population. So let's move in to identify the pieces for today's discussion. Today, we will identify the population demographics of the MSSP and MA programs, the similarities and differences between these programs, and the different resources and infrastructure you'll need in order to take on these contracts. So let's take another minute and do another poll.
Thank you, Maria. So this poll question is asking which payer model is preferred by your organization. Some of these contracts are a lot easier to understand, analyze, comply with than others. So we just want to understand what does our audiences feel on these different contracts. Okay. Response has slowed down quite a bit. I'm going to close out the polling and share the results.
So it looks like, since a lot of you are already in the Medicare ACO MSSP programs and NextGen programs, as we saw in the first poll, a lot of you also prefer them. However, it looks like there is an even pretty close split between the Medicare Advantage and commercial ACOs as well. So let's take a look at who is the population. Let's compare and contrast the MA and Medicare beneficiaries. According to the CDC, 70% of Medicare beneficiaries have at least one chronic condition. And we're probably not at all surprised to learn that the majority of them have hypertension, hyperlipidemia, and diabetes. However, on the next slide, you'll see that the MA population is typically younger and healthier. On the left, you see that the Medicare population is aging, and they tend to shift towards Medicare. It's a pretty even split between genders, but it appears that a large portion of Medicare patients identify as Caucasian. Interestingly, on the right, you see that there was a shift in risk scores between the MA and fee-for-service populations. At first, the Medicare population had a lower risk score, and then it was overtaken by the MA plans. One of two things could be happening here. Either the MA population got sicker, or the providers simply got better at coding patient acuity. As the baby boomers continue to age, there's going to be a growth in both the MA and Medicare populations. As you can see based on the analysis done by the Kaiser Foundation, Medicare enrollment will continue to increase through 2035. There's also geographic variation in the number of MA enrollees. It looks like some of them are in warmer climates, like California and Florida, unsurprisingly. So let's move on to the meat of the discussion for today.
Thank you, Maria. All right, so we're going to get into similarities and differences. It's extremely important to understand these perspectives in order to create alignment and parity within your contracts. Since the Medicare Shared Savings Program, or Next-Gen ACOs, are designed by CMS, we know that there's very little we can do to change those contracts unless you submit during the RFI process. So it's a much slower change. However, when you're dealing with private payers, you have a lot more flexibility with your contracts. And the closer you are to aligning your different payer contracts together, the better you will be at helping your providers understand which quality metrics they need to comply with and how to really work your contract so that you're in full compliance. Additionally, you want to ensure that the burden is not put on your physicians, and you do not at all costs want your patients to understand that there is a difference at all in the way that they're being treated. Physician burden is a huge issue, and this really aims to minimize that effect. So with that, we're going to turn this over to Maria and Dr. Gray, and we're going to have a little discussion about some of the different points you may want to talk about when you are at that negotiation table.
All right, thank you, Amy. But you know, an important point has already been mentioned, and that is that the objective in your contract negotiations with Medicare Advantage companies is to unify as much as possible the process. Now, doctors will clearly be more successful in caring for patients rather than chasing insurance companies. Before I get into it, I would like Maria to just amplify a little bit on the patient profile elements between MA and MSSP.
So as we saw earlier, the Medicare Advantage population tends to be younger and healthier patients, which then results in the lower HCC scores. Conversely, the MSSP population tends to be older and sicker, and they usually have higher HCC scores. However, on the previous slide, we saw that the Medicare population currently, the Medicare Advantage population currently has a slightly higher HCC score, and that's probably due to increase in coding acuity and patient acuity coding. Dr. Gray?
Yes, you know, an important piece of this whole process is the attribution, that is the assignment. And it's really a key program methodology used to identify beneficiaries associated with the ACO. Furthermore, it identifies the population for which the ACO is held accountable. Hence the name Accountable Care Organizations. Attribution is important on both sides of the ACO equation. It's used in program operations, for example, to develop quality reports, determining the ACO's financial and quality performance. It's even used to determine eligibility for savings and losses. Now, generally, attribution is determined on the basis of actual use, that is, actual use of primary care services. We know that also as plurality. But there's a bit of a mix on the CMS side. CMS now allows choice on prospective or preliminary prospective with retrospective reconciliation. In other words, a double look. But in fact, next-gen and direct contracting models use prospective only. Now, simply stated, if you're going to be clinically and financially responsible for a person's care, you need to know who they are. Now, attribution is increasingly important as this payment process is tied to value. Now, understanding attribution on the MA side is equally important and really must be included in your negotiation process. Very important. Now, since there's no universal standard as yet, stay tuned, just be aware how attribution drives outcomes and drives provider engagement. Let's take a look at referrals and networks within the context of Medicare Advantage and Medicare MSSP. Of course, under the MSSP model, CMS has an open network. You have an open network. The primary care physician is then fully engaged as a proactive quarterback in managing that patient population. There is a lot of outreach involved, identifying, managing, calling, seeing, caring for that particular patient. Now, presently, on the Medicare Advantage side, it really depends on the program model. If it's an HMO care network, which tends to be narrower, it will therefore direct patients through the primary care physician in the traditional HMO style. But on the other hand, if it's a PPO model, preferred provider organization model, there seems to be and is more freedom to access specialists directly. Although, to attain full financial advantage, the specialists and the primary care physician must be in a network. Now, just know who is in your network as you step into this new world. On the payment side, it helps to understand how the MA plans are paid, so that during the negotiation process, you can understand their point of view. In that situation, Medicare Advantage risk scoring is central to the payment that the MA plan receives from CMS. So you can really expect a very high level of sensitivity here from the plans, from the Medicare Advantage plans on this particular issue. Now, in contrast, under the MSSP model, although risk is very important, the benchmark is heavily financially focused, community-based, and does not consider changes in acuity as part of the payment mechanism. But don't ignore that, because under risk, assessing the risk of your population is clearly an important function of managing the care of that particular patient. While there are, of course, similarities on the MA side, there will be a variability as well. Under the MSSP equation, HCC, the hierarchical condition category, is the standard. Salient's application measures risk at a beneficiary level monthly, so that early intervention with the sick patients really becomes possible early in the year, therefore improving the chances for better outcomes and, of course, financial reward. On the quality metric side, the MSSP metrics are the same for all ACOs, and they're determined upfront by CMS. Now, while there are, of course, similarities on the MA side, there will be variability from MA company to MA company. Now, there are conversations where it already started to unify the quality metric process, but we're not there yet. Just know that all of these metrics are HEDIS-based. So nonetheless, here is the important point. Your objective in contract negotiations is to show that the ACO physicians, your physicians, are quality-oriented and use that as leverage to make the quality profile as unified as possible in your MA contracts. Now, Maria, tell us a little more how this fits into the post-acute paradigm, that is, the differences between MA and MSSP. That's another important piece.
So in the Medicare Advantage program, post-acute care management, you see shorter SNF lengths of stay, and the providers provide tools to help manage that population. Conversely, on the MSSP side, you'll tend to see a longer SNF length of stay, hovering around 21 days. And at this time, CMS does not provide any tools to help manage that population. The only thing you see is really the nursing home compare and home health compare quality metrics that you'll see on the CMS website. Amy, back to you.
All right, so we're going to take our third polling question, and it has to do with alignment of quality metrics. So for those of you in our audience who have multiple contracts, we're going to try to find out, have you been able to actually align your quality metrics with some of your providers and payers? All right, the polling has slowed down. I'm going to close out. And we'll share those results. So it looks like the majority of you have not, but it's not that far off. So some of you have worked with some of your providers and payers to align your quality metrics, and that's a huge step in trying to play on the same playing field and be able to compare apples to apples exactly how your providers are performing. So it's a huge step. Now, the next part of our discussion has to do with resources and infrastructure. Whether you have your multi-payer set up already, or you're looking to start a new payer contract, maybe in a different arena, maybe you're starting Medicaid, or maybe you just have another payer that you're working with, you know that there's a lot of resources and infrastructure that need to be set up ahead of time. So Maria and Dr. Gray are going to walk you through various pieces that might play a big part in your organization so that you're prepared to take on these value-based contracts.
All right, it's been said that care and case management is a cornerstone of successful patient care. It is the culmination of that team effect that you've heard about for the last decade or more, and which we are truly finding necessary for successful outcomes, both financially and clinically. The process activates the therapeutic intervention that takes place in the hospital or in the office exam room. Your information must be able to identify and track patients that need preventive intervention or special attention in the seemingly never-ending effort to support the triple aim. And you know, better care, lower cost, better patient satisfaction. But remember, every patient does not need case management. However, keep in mind, your population needs care management. Specific patients need unique care, have unique needs that need specific management. For example, your COPD population, your chronic obstructive pulmonary disease population, really needs to be monitored and managed during flu season to make sure they have their flu shots so we don't exacerbate the underlying medical problem. So be prepared to make this process very central to your success. Now, the other one is huge. It needs to be underlined and in bold, and that is social determinants, because we are finally paying attention to the patient's environment and how it influences clinical outcomes. Now, in simple terms, what good is it to provide insulin to a diabetic who doesn't have a working refrigerator? Most of us know the answer to that question. Now, in a recent blog on our website entitled Social Determinants, a Clinical Metric in Disguise, this understanding of social determinants is clearly illustrated, and the importance of them in managing patients clinically is amplified. Now, in the risk management world, you know, housing, transportation, social surroundings then become an important tool to drive financial and clinical success. On the compliance side, and yes, we are in a compliance world, I suppose it's not necessary to say that the contract between the MA plans and your organizations is real business, because it is. There are obligations on both sides of that equation. Compliance and tracking compliance with the contract provisions then becomes an important part of that business. Now here's where your data analytics system becomes very important. Your system must have the ability to monitor individual patient progress. That's the care and case management piece. Track the individual physician performance. That's that managing your physician piece. Always keeping in mind that the purpose of monitoring is to help patients and their doctors grow in understanding and improve performance. Yep. Now, occasionally you're going to have to use this tool to make data-driven decisions, to disengage from non-compliant patients at the practice level, or potentially disengage some of your doctors at the ACO levels. Oh yes, one more thing. Do I have to mention HIPAA compliance? We all know that. We all know that story very well, and the importance of it in our overall compliance process. Now, on the patient engagement side, the wellness visit is the chance to contact everyone at least once a year. Now, we have seen that complex patients often need plan corrections from time to time, and even those with chronic care need plan corrections even on a more regular basis. But I'm talking about your population as a whole, needing the chance to catch up on preventive measures. Remember, that's part of your quality scoring. Yep. And by the way, all of that, the wellness visit, the preventive measures, it's good for your patients. It's good for their outcomes, and it helps you improve your scoring on the quality side. Now, Maria, tell us how provider engagements are important here, and then how data analytics support the whole process.
It's really important to make sure you've engaged your providers and that you have a physician champion for each of your ACO initiatives. In many instances, you'll have the office manager identifying areas of opportunity and then creating initiatives around that topic. However, if the physician is not informed about these efforts and is not spearheading these efforts, it's going to be difficult to ensure the whole practice is engaged. Additionally, the physician champion will ensure that the other providers in the practice are also engaged. For example, a clinician, such as for transitions of care visits, for example, it's really important to ensure that the PCPs are integrated into that entire process and understand the value and the importance of these initiatives. Equally as important is your office workflow. In addition to the physician champion and provider network engagement, it's really important to make sure that the staff has also been brought into the process and understand the importance of the team-based model. An example of an initiative where it's really helpful is emergency room utilization reduction. Your practice may implement an initiative around increasing access to the practice. However, if you don't have solid workflows and triage mechanisms to help your staff discern whether a patient needs a same-day appointment, you may run into issues when your patients overutilize the emergency room. And of course, data analytics. It's really important to ensure you have one data analytics platform to be able to integrate data from multiple sources, such as ADT data, EHR data, claims data, as well as multiple payer data. Otherwise, what you're going to get is you're going to get stuck in multiple systems for the same initiatives without having an apples-to-apples comparison of how your initiatives are doing as a whole, or worse, you're going to have Excel spreadsheets everywhere without a comprehensive view of your practice performance. Amy, can you tell us a little bit more about how Salient's data analytics platform performs?
Absolutely. Thanks, Maria. So to Maria's point on the need for data analytics, I'm going to show you a sample scorecard, which you'll see on your screen. And this is a quintessential tool for continuous process improvement. And that's the foundation of any value-based payment contract, is taking a look at how your providers are performing and ensuring that you're improving over time. And it's important to see physicians and their percent change across your key performance indicators, so that they understand how well they're doing individually. It's not enough to just compare them to the whole cohort, because you're going to get the same responses every time. My patients are sicker, I see cancer patients, I get referrals from this doctor, and so forth. So showing them where they stack rank across the whole cohort of providers, but also comparing themselves to themselves from another prior period of which they made a change. So if last year you saw that they were at a baseline number, you implemented an initiative, you'll want to check in on that to see how they're performing now. How did they perform over time? So to take a look here at the scorecard, you can see all the way on the left-hand side that you're able to select your payer contract. And it's also important to see from a perspective of a provider how well they're doing across all of their different contracts in one spot, so that you don't want to see numbers that are going poorly for one payer and doing a little bit better for another. You want to ensure that this doctor is performing well across all of them. And you could also pick and choose which ones so that you know which initiatives need to be put forth. So the different key performance indicators we see here are the ones that are crucial for your organization to comply with your value-based payment contracts, whether it is ACO or Medicare Advantage. So we always take a look at the spend. What does the spend look like per member per year or per member per month? And what is that change in your acuity of illness or your medical risk score? That's really crucial for Medicare Advantage, like Dr. Gray pointed out. But it's also important for the Medicare side, the shared savings and ACO programs. It's becoming more and more important, so they've just upped the percentage to plus or minus 3%. But it used to be 1%, and so that's becoming really important with your benchmark setting. You'll then move into annual wellness visits. So in Salient, a lot of times we use this as a proxy for quality because so many of your quality metrics can be addressed within this type of visit. It's also a measurement of provider engagement. Are they even doing this visit that you guys are pushing on them as an administrator? You want the wellness visit completion. It helps with revenue. It helps with that patient-provider relationship. And it also shows patient engagement because they're coming and having discussions with their physician. Another key KPI is continuous attribution. How sticky are your practices? Do the patients truly enjoy going to see this physician, and is it the practice that they call their provider? A lot of new rules are out there, voluntary alignment. You want to make sure that your patients are really staying with those practices and not going wherever they see fit. And a really unique measurement we have is the percent of beneficiaries seen on a quarterly basis. So to practice population health, you have to understand that CMS puts out numbers. They say about 70% or more of your total population have one or more chronic conditions. If that's the case, then you must be seeing your beneficiaries at least 70% on a quarterly basis because you're properly managing their chronic conditions. So that's a true engagement of the physician and also a great measurement to understand how well they're working with their patients. High frequency of primary care usually helps to decrease emergency room utilization, which Maria talked about. Now, the percent change in visits is across all different visit types. When you get data from these plans, you're getting information on skilled nursing facility utilization, home health, even observation, ER, hospital, and hospice. So you're really getting the full perspective, not just what's going on in the four walls of the primary care physician's office, but what's going on outside and how are your initiatives driving change in utilization. You'll then want to take a look at transition care management. This is a huge piece with care management and helps to ensure a decrease in readmissions, which is always up on the top of everyone's list for quality metrics. And it also helps to re-engage the physician who was the point of care for that beneficiary prior to them being ill. So it really sends them back to the community, which is where they need to be in order to really decrease total expenditures in that post-acute care setting. The last piece is change in inpatient readmissions, which we have separated out into 3 different time frames. Everyone knows the 30-day readmission mark, and that's what you're being graded on right now. But we also have a 90-day and 180-day readmission rate, and it's really important to push out those time frames if you are a provider organization because your contracts span longer than 30 days, and if you're an accountable care organization, you're accountable for these patients for over a year. So you want to ensure that they're not returning to the hospital after that 30-day mark. It's not a gaming system. It's truly practicing population health and looking at the long term of your patients. So scorecards like this are really important to help with continuous process improvement, and it's also really important for you to be able to look at it across all of your different payers. What are the commonalities across them and what are the differences? Because that's what you're going to need in order to figure out who's helping and who's hurting your organization. So Salient has been working with our existing clients to provide data analytics across all payers, and we have 2 different interfaces for our spectrum of user types. So a lot of these organizations have a continuum of users. Someone who might be extremely data savvy, like a data analyst, may want ad hoc capabilities. You might want to customize reports or ask a lot of those why questions. So, which home health agencies are we using most, and what types of patients are going there based on DRGs and diagnoses, etc. You really want to know the details and the why questions that some of your providers might be asking, so you want that capability. So we provide that to our users in Salient Interactive Miner, our ad hoc interface. The other interface might be for the other spectrum of users or continuum of users. We might have board members who just want high level. How is my organization, how do they look across a number of payers? Which contracts are doing well, which might not be doing so well? So a high level view might be best displayed in a dashboard type of interface. And then you might have your day-to-day workers. You might have care managers who are really working on your acuity of illness and understanding transition care management and chronic care management. So you might want to have some dashboards preset for them to utilize that can then be aggregated for those board members making those bigger decisions. So being able to support your continuum of users is going to be extremely important, and that's something that we provide to a lot of our clients, is that full capability with all of your users. We also provide a 45-day free trial with your own data, and that means we backload all of your history plus a month of claims so that you could actually test drive the car before you even buy it, which I always find to be extremely important. So with that, I'm going to let Dr. Gray take it away for our wrap-up.
A fundamental question is, why are you in the ACO business? Now, as our healthcare system changes, the ACO, the physicians, and the patients become the new center of the universe. This is good. This is what should be happening. And it is a natural progression for the ACO to move beyond the CMS-driven MSSP model and add multiple payers under their management, because it's part of the overall community responsibility of an accountable care organization. The shift is all part of this value-based payment process that finally gives the full management of the clinical outcomes to the physicians and the patients. These are logical parties, and they are finally in a position to potentially manage outcomes. And additionally, of course, as this shift happens, other things occur around the financial responsibility, which is closer to the care, along with the risks and rewards of the process. Now, excellent healthcare means high performance standards from those providing or leading the care. Key industrial leaders has said, the key to high performance is timely and specific knowledge in the hands of the value creator at the point of value creation, and that value creation is at the bedside in the hospital or at the exam table side in the office. Now, the community-based ACO is the nearby administrative process led by physicians, managed in direct cooperation with physicians to provide this useful analytical data, decrease duplication, reduce the administrative burden, allow physicians to focus on the clinical outcomes and to meet the goals of the triple aim. This is the why of clinical practice. You know it. Better care, better cost, better patient satisfaction. Thank you.
All right. Thank you, Dr. Gray and Maria, and thank you all for listening and joining in on the webinar. Garrett is now going to host a number of questions. So with that, I'll let Garrett take it away, and we'll be open ears for our questions.
All right. Well, thank you all. That was a really wonderful presentation and very thorough. We do have some questions that came in, and so these are not directed at any one specifically, but I'll just throw them out there for you all. The first question is, in New York, is Salient serving the state government or providers or both?
This is Dr. Gray. In New York, Salient supports the Medicaid program for the state, and that is the Medicaid reform process that's been taking place, and also the district program, which is a huge, how do I call it, reform and revolution within the state of New York. In that process, they do provide data to providers at the community level, and that's where it's happening presently.
I do want to add to that. I wish I had a organizational structure of how the state is accessing the system, but essentially it's one solution that's being hit by a number of departments. So the Department of Health is accessing it, and they have a limited set of the full set of data. And then there are other personnel within the state that are accessing it. So when I talk about governance, there's user login, and it's very protected as to which patients they're able to see, what data they're able to get their hands on, and it's differentiated by department. So it's very complex in the sense that it's holding all of the transactions, but also it has specificity as to who's accessing that point.
Okay, great. Next question is, can MIPS quality scores be used in MA negotiations to demonstrate high quality of the providers?
Absolutely. This is Amy. I'm going to take a stab at that, and Dr. Gray and Maria, you can join in. So when you're talking to some of your payers, it's important that you have all the research done ahead of time, because they've done some as well. And to be able to provide information to them that is important is going to span a number of key performance indicators that we were sharing. So MIPS quality scores is huge, because that's telling you how are you performing across the government specified metrics. Now, before MIPS, we had QRURs, so quality resource and use reports. Those were helpful as well. So the QRURs, MIPS reporting, if you're not doing MIPS and you're part of an ACO, your GPRO reports. And then additionally, you're going to want to show some of those other factors. When I worked with an organization that was solely an ACO looking to branch into Medicare Advantage, they used all of their ACO data to say, hey, look at our numbers, because we don't have a network, we don't have a referral system, and we're able to work our beneficiaries in a certain way and follow a certain pattern that was actually enabling us to achieve shared savings. So by using the data that was provided for one contract was really helpful in looking at another. So absolutely use your MIPS quality scores.
So to summarize that, very good advice. Use all the data you can. This is business. This is contract negotiations. You need to be able to show that you are a high-performing, quality-based organization. Use whatever data is available to make sure that argument is solidly placed. You've just heard some good advice from Amy.
And to add to that, this is Maria. Wanted to specify that I went to the National ACO Summit in DC last month. There was a lot of discussion around having the industry and the commercial payers partner with the government to align on quality metrics.
Okay, well, great. Our last question here is, are provider engagement initiatives more successful with PCPs than specialists?
This is Amy. I'm going to take a stab at that quickly. It's not necessarily that a certain specialty is better at value-based contracting than another. I think some of the contracts out there just support one type more than another. And there are different ways to utilize specialists and primary care physicians. So it has been proven time and time again that using the primary care physician as what Dr. Gray referred to as the quarterback has been extremely helpful in that effort. And then creating appropriate referral networks, whether it's a formal referral or just a preferred provider network, is going to be extremely helpful with your specialists. Now, with payment mechanisms, it becomes a little bit confusing because many of your specialists are going to be the ones that are increasing your overall expenditures. If you have a hematology oncology group in your accountable care organization, it's going to drive costs. And you're not necessarily looking to stop that. You want to make sure that they're doing the best practice that they can be doing, but it might affect your overall numbers. So whether their tax ID number is in your organization or not is something you have to analyze ahead of time. But I will say that it's not to keep them out of the organization, but just use their specialty in a different way that complies with your contract. It's just important to understand how the numbers work.
And, you know, in the past, hospitals and specialists were the previous center of the healthcare universe. That is purposefully shifting to the primary care doctor, who will be able to coordinate that particular patient's care. The other important thing here is that the primary care physician will lead with the introduction and accomplishment and completion of preventive measures to keep people out of the hospital, out of the emergency room, and away from the specialist, not because they're bad, but because that's not the beginning of healthcare. And I think as you've heard, specialists, and in fact I was one, a specialist, very focused on just managing breast cancer and surgical management, diagnosis, and treatment. It was very important that specialists, and it is very important that specialists remain part of the circle of high performance. You keep in mind, and is the fact that hospitals are now a cost center and need to be carefully managed in terms of their utilization. So no one is depreciated in this new continuum of care. It's just that the primary care doctor leads that process because they have first contact with the patient, who is now, by definition, the center of the universe.
All right. Well, thank you guys all very much. Those are some wonderful questions and some great answers. And so that's going to actually conclude our presentation for today. And I want to thank again our speakers. And for those of you who may continue to have questions, feel free to reach out to any of the presenters directly. You can see on the screen right now is their contact information and numbers, or you can reach out to us either way. Also, wanted to let you know that this is, again, being recorded, and so you will be able to find a recording of this at the ACO Exhibit Hall website. As you can see up in the right-hand corner, it's www.acoexhibithall.com in the library in the reference section. So there's a webinar area there. And also, I would encourage you all to go and visit acoexhibithall.com and visit the Salient virtual exhibit booth there. And that's where you can learn more about them and connect with their team. So thank you all for attending today. I hope you found it useful and informative, and I hope you have a great rest of your day. Thank you very much.